Bismillah ar-Rahman ar-Rahim. A vascular case presentation by Mr. Omar Farouk about rupture of superficial femoral artery. This is an 81-year-old patient with sudden fall on the ground who had severe left leg pain. He is hypertensive, dyslipidemic, previous MI, and he had CABG 12 years ago. And notice here that his age is 21. On examination, we have found that there is a hematoma on the left thigh, and you can see the left thigh was pulsating around that area, and hematoma extended hour by hour in the upper thigh and the lower thigh situation. Initially, diagnosis of fracture femur was made, but on normal plain X-ray, this diagnosis has been excluded. Patient continued to complain of a severe pain, and the hematoma continued to enlarge, and it has reached after 6 hours into the left side of the groin and also extend into the left flank. At this stage, we diagnose him as having ruptured superficial femoral artery with no aneurysmal formation, which has been confirmed by duplex scan. Duplex scan had showed that this is the amount of rupture. Picture was not very clear due to the haziness on the left thigh, but there was no aneurysmal sac, and the whole thigh was pulsating. Notice also that he had left DVT at the same site, which is very unusual to have DVT and rupture aneurysm at the same leg. Patient, after passing 6 hours, had a severe chest pain and become cyanosed, and the clinical diagnosis of pulmonary emboli has been made, and on CT scan we have discovered that he has a big embolus into the left pulmonary artery, which we were unable to give him anticoagulation. So we discussed with the patient and the relative, and we put a plan of having IVC filter, then endovascular management to the rupture aneurysm, and surgery as a second option. How to treat pulmonary emboli with a ruptured superficial femoral artery is definitely an intriguing question. So we went in from the right common femoral vein, and we did deploy IVC filter of trapeze permanent type, not a retrievable type, and at least by this we are going to prevent any more shower of emboli if we need to do surgery on that patient. We discovered that as most octogenarians, he has tortuous anatomy, and you can see here from the crossover right internal mammary catheter or rim catheter that his crossover was very tortuous. You can see 180-degree loop, which is very difficult to cross, and here is the angiogram. So very typical anatomy. After passing a stiff guide wire, we were able to make this anatomy or bifurcation at least to be workable. He is also grandfather of very famous Egyptian cardiologist and a friend of mine, and the grandfather of an Olympic boxing Egyptian champion. So after passing crossover with difficulty, with about half an hour time, we were able to pass the wire in superficial femoral artery and to have an angiographic picture. And you can see here the rupture, and you can see the amount of bleeding, but you cannot really localize where the origin of the rupture is. So we tried to put one needle at the upper end of the rupture, what we think it is, and one needle at the lower end, and we tried to have another picture to see the leak. You can see you're not sure where it is coming from, but maybe you need to change the position of the needles. After this, we had another picture, and with this picture we were maybe more or less think that the rupture aneurysm is between the upper needle and the lower needle. We had covered stent, which is covered wall stent, which was of a diameter of 10 millimeter by 10 centimeter in length, and we only have one covered stent as excess stock. So we put a vertebral catheter, try to judge where is upper end, and you can see here this is a vertebral catheter, injection of a dye, and you probably think that the origin of the aneurysm may be above this needle. So we wanted to change this needle to have a little bit of up position, and maybe this needle is okay, you don't need to change it. So we put again the catheter at the lower end to make sure that everything is right. So after injection here you can see blood is flowing nicely down below, so maybe this position is correct, and we, as you can see, we have moved this position high up. Here is a covered stent, and on deployment from a crossover you will notice that the covered stent will jump forward, and you need to compensate it by pulling back. Whenever it jumps forward you need to pull it back, and this is a technique you must use, and use fluoro continuously during stent deployment. So we're finally able to deploy the stent roughly between these two needles from a crossover. After this we have injected an angiogram after deployment of the stent, and you can see the angiogram that we have endoleak type 1. You can see there is endoleak, and this endoleak type 1 either coming from the lower end of the graft going up, or going from the upper end of the graft going down, and the endoleak is roughly around this position. So we said fine, we're going to inject the dye from inside the endograft, from inside the channel of the balloon, and you can see here that the channel goes nicely and there is no endoleak, at least from the lower end going up. Then we have another injection to make sure how things are going, and you can see here a definite endoleak type 1 from the upper end, which is very obvious. You can see little bit of channel, small channel there, which is supplying the endoleak. So we said we're going to redilate it, and because we didn't have 10 or 11 millimeter balloon, we said fine, we're going to use two balloon. One is 8 millimeter and the other one is 4 millimeter in diameter. So we have two balloon, one 8 millimeter, one 4 millimeter on each other, trying to inflate the proximal end of the graft. And this is a double angioplasty to this patient. After this, you can see this is the final angiogram. We're able to lower down the amount of endoleak. If we have a look, endoleak has become lessened, and the patient pain have subsided dramatically, and we can see on the spot that he became hemodynamically more stable. His blood pressure start to rise from 90/60 into 120/80, so his blood pressure started to increase. If you go to literature, a spontaneous rupture of superficial femoral artery is actually a rare condition. There is only 5 reported cases worldwide, and it occur with and without aneurysmal disease, and it is used to be treated surgically, but definitely endovascular is very good weapon for vascular surgery, and presence of DVT, which was not recorded before, definitely complicated the management. My conclusion and take home message that all peripheral vascular disease are treated primarily by endovascular management as the first option. Clinical decision making is an art, and you must weigh the pros and cons of each decision you are having, and be ready with the covered stent in our cath lab. I think a covered stent peripheral and renal covered stent again is essential in cases of rupture of superficial femoral artery or renal artery. This is my conclusion, and thank you for your attendance.